Welcome back to The Thinking Mind, a podcast all about psychiatry, psychotherapy, self-development, and related topics. If you've listened to this show for any length of time, you know that from time to time, we have conversations on the podcast about the limitations of psychiatry, the limitations of the medical model as a way of dealing with mental health problems, and to some extent, how mental health systems could be improved. These kinds of conversations emerged organically as the podcast developed. It was never really an explicit goal of the podcast to discuss how mental health systems could be improved. As such, it's certainly not my area of expertise. But I do think the conversations I've ended up having in this area have been some of the most valuable that I have had. And I've had those conversations with people like Rose Cartwright, Joanna Moncrief, Roberto Mezzina, Richard Bentall, and others. Today, we're continuing that conversation with Marieke Bigg. Marieke is an author of fiction and nonfiction in the areas of women's health, mental health, and the history of science. She holds a PhD in sociology from the University of Cambridge. She's currently also training as a psychotherapist and works as a peer support coordinator at the mental health charity Mind. Her most recent book is No Such Thing as Normal: Disorders, Diagnoses, and the Limits of Psychiatry. In today's conversation, we discuss whether there is any value to this idea of normality, and is normality something we should even be discussing when it comes to mental health? We talk about what we get wrong, about the line between so-called sanity and madness, why a medical approach by itself can be very limiting for people dealing with complex mental health problems, the relevance of social and cultural problems when it comes to mental health. We discuss Marieke's view on neurodiversity and the psychedelics renaissance, and much more. Before we get into today's discussion, one quick announcement. As I mentioned on the podcast last week, the Thinking Mind blog is now out on Substack. This is headed up by Dr. Rosie Blunstone, a psychiatry and psychotherapy registrar who's been working behind the scenes on the podcast for a few years. We're going to be posting a monthly newsletter on the Substack, which is a companion to the podcast. It will feature emerging discussion points within mental health, some news within mental health and mental health technologies, reviews of recent podcast episodes, discussions around popular books within the realm of mental health and psychology. The first edition of the newsletter is out now, and the link is in the description. And in this first edition, among other things, we discuss the origin story of this podcast and how it got started back in 2019. As I said before, we'll be posting a newsletter at least monthly, and I'm hoping that myself and Anya will also be able to post ourselves on the Substack in between. We're excited about getting to share more content with you guys related to the topics you're interested in a new format. This is The Thinking Mind. If you'd like to support the podcast, you can check out some of the links in the descriptions with regards to the services we offer. And now, here's today's conversation with Marieke Bigg on her new book, No Such Thing as Normal. Thanks for listening. Marieke, thank you so much for joining me.
Yeah, no worries. Thanks for having me on.
As we were saying offline, obviously there's a huge amount in your book. One can learn about the limits of psychiatry itself and maybe how mental health can be done differently. I'm always interested in the underlying philosophy of ideas. And underlying this book, I'm thinking about, it's in the title, No Such Thing as Normal. Is there any value to normality, or is there any value to striving towards some sort of ideal? Do you have any strong thoughts on that?
Yeah, I think normality, when I think about helping people, going through a difficult time, normality to me seems a little bit besides the point. I think, I'm also a trainee therapist. And when I think about working with people, what I'm trying to do is to help them arrive at some kind of understanding of whatever's happened to them, to empower them to find ways of coping, ways of making sense, ways of kind of moving through that. So I don't really see why you need a concept of normality in doing that kind of work. And I think it is that kind of work that, we're talking about when it comes to supporting mental health.
I can definitely see there's a way you can enforce normality, can't you? Or you can prescribe normality in a way that I think would be counterproductive. You can say, you're here over here and you're doing things in some way that's wrong or, abnormal, and you should be coming over here to this, version of normality, which I am going to prescribe for you, and I'm going to tell you what it looks like. And that's definitely, I think, a use of this idea of normality that can be counterproductive.
Yeah, no, I think I agree. I think that normality and the way I sort of approach it or discuss, or critique that kind of standard in the book is very much related to power and how power is enforced, in a situation where one person is generally regarded as the expert, so the psychiatrist or the therapist, and the client or the patient is the one who, needs help. And with that power kind of imbalance, it's very easy to enforce kind of standards and ideas of normality on someone that might not make sense to them.
Yes. And I think that's especially relevant when someone's in crisis, in a very acute situation, a very distressing situation. At the same time, I'm thinking, maybe especially in the medium to long term, and especially in forums which are more about like psychoeducation, is there not a value about describing certain, I'm not 100% sure if ideals is the right word, but let's say ideals for now to strive for. So for example, you might talk about the value of, for example, being able to delay gratification, to not be impulsive necessarily or be overly reactive in any particular situation, or the value of mutually beneficial relationships, forming mutually beneficial relationships with others, and how that can help, and various other values you might talk about, less in a kind of strict, I'm enforcing this on you sense, and more in a kind of, this is how humans have gotten along for a long time, and we find in large groups of people, when we look at studies of large groups of people, this seems to be pretty good path to go down. Is that a use of an ideal that might be more beneficial?
I think when you're supporting someone and working with them, it's generally helpful to understand what someone, needs or wants. You need to arrive at some kind of understanding of what they think is the challenge they're dealing with in their life. And if then based on that, you can offer something in terms of, this is a way of working with this, or, this might help this, you can offer someone that, definitely. But generally, I think it's much more helpful to have someone discover and create and innovate in order to find their own way through. And I think people are really great at doing that.
This is really interesting. I mean, totally agree with the idea of, it has to come from them. Like, what do they want? And when I'm working with someone in a psychotherapy or coaching forum, I mean, even psychiatrically, I would say super important I think the conversation starts with them. What do they want? And I think encouraging an individual's tendency to innovate. So maybe Carl Rogers might have called this the actualizing tendency, to come up with strategies and solutions to those problems. I think that's super useful. At the same time, I'm thinking about the tension. Let's just think about it politically, the tension between right and left politically. So as far as I can tell, the political left will generally emphasize the value of innovation and individuals coming to their own sort of conclusions about how best to live their lives. And then conservatives will tend to emphasize tradition. Like life is, like from a conservative point of view, it to be something like life is really hard. We need to rely on what's worked, because life is too unpredictable to be coming up with your own rules. And somehow I find when it comes to mental health, there's similarly this balance of both, of yes, absolutely encouraging the individual, and then also trying to figure out what works, and not really in an enforcement kind of way, but in an optionality kind of way, giving people the options of like, these are some things that have worked for other people. Perhaps they might work for you as well.
Yeah. And I don't see that as a tension. I think that the two can coexist very well when you operate from this basis of, empowering the person you're working with to make their own choices and decisions. And I think from that place, you can explore what, this individual has experienced themselves, how they make sense of it, empower them to figure that out. And also, again, offer them, what's been done in the past and what's available. And also, I think a tension that I did feel when writing the book was one between, criticizing some of the kind of medical approaches to dealing with mental health, and at the same time recognizing that within the world that the sort of society we're working in, the mental health care systems we're working within, this is what's available to people. Getting a diagnosis can make a difference to someone's life. Getting a prescription might really help someone, especially when there's not many other options available to them. So there's always this tension for me between working within the kind of system you have and empowering people to get some form of help based on what's been done before, and supporting people and kind of reaching for a system in which we can have much more individualized care that really empowers people to make their own meaning and find their own way through.
Yeah, and I could see in your writing how you were wrestling with that tension and really trying to be responsible and not, it's easy nowadays to write something very polemic, something that's going to be very sensational. But I could see you really trying to wrestle with that tension in quite a responsible way. And it really reminded me of the tension I felt just training as a psychiatrist, working as a psychiatrist, often in extremely imperfect conditions, where you're dealing with problems like lack of resources and just the problem, I think, when you're dealing with large numbers of people, for example, a community mental health team that is responsible for, say, 400 people with maybe 2 doctors on it and other stuff, obviously. But similarly, you're dealing with tension all the time, ethical tension, like how best to work within an imperfect system. Digging into some of the core concepts of your book. So why do you think the medical approach to mental health, at least not by itself, might not be the best approach?
Yeah, I mean, there's various reasons, but it really comes back to what we've been exploring, this idea of denying people choice and agency in figuring out their own understanding of what's happened to them and figuring out a way to deal with that and respond. What the medical kind of view often does is it takes a human experience of suffering and problematizes that, pathologizes it, treats it as something that needs to be cured in isolation, and often misses the surrounding, context of a life and the kinds of experiences that may have led someone to feel a particular way. So I think it's this denying people a real explanation that I think can be really harmful to just someone in their life where, these experiences really take place and where they're trying to find a way to continue to live on. I think that the medical view treats an issue in a person rather than a whole person. And I don't think that's the most helpful way of dealing with mental suffering.
Yeah, and a person, I suppose, really stripped of their context, and that's the context of their life, the context of their family, culture, wider society.
Yeah, definitely. And like you said, I really grapple with that tension in the book between also trying to acknowledge, what we have to work with, that, the medical tools available have helped a lot of people, but also trying to just draw more attention to this much bigger context that we need to look at, because also in developing a response as a kind of society to mental health, when we ignore the experiences that make people feel depressed or anxious, the real life problems that drive people to feel distressed, when we ignore those and treat individuals instead, we're also detracting from, attention and resources for the kinds of services that could really make a difference. So, social provision, for example, making sure people aren't stressed, overworked, poor, struggling to find housing or community, things like that. So it's such an important part of the picture that I just think we need to give much more attention to in a society where we discuss the medical view a lot and the social view less.
Yeah, so I guess in a way you're saying if you don't get the diagnosis right, you can't get the treatment right. So if your diagnosis of depression, if depression means, there's something going wrong for you at an individual brain level, that your mood being low isn't saying anything important. There's no signal there. It's all noise. And your mood being low, I'm talking about depression really because depression is probably the most common, and anxiety by far. It's not capturing anything useful about your life or your situation or your context. It's just an aberration of your brain. What that means is all the treatments are going to be brain focused. And, we're seeing, the limitations of how helpful purely brain-based interventions are. And although they can be very useful in some individuals, you wouldn't want to have a society that doesn't have access to them. They're certainly not keeping up with the huge rates of depression and anxiety. They don't seem to be as efficacious as you would expect if we're dealing with a purely sort of biological disorder. Whereas, what you're saying is if we can understand that depression, someone being depressed is something meaningful about their life, then we can have an entirely different conversation about how to make people's lives better, I suppose.
Yeah, exactly. And I really like that way of putting it, that when we view this as a medical problem within a person, we deny someone the meaning of their symptoms. And when we do interpret those symptoms in context of a life, of things that have happened to someone, we see that they're actually pointing to problems that we can address using the tools we already have, and that we might not need, extensive brain scans or studies or, the thousands and thousands of pounds that go into that kind of research to help people right now.
Yeah, one of the things that's always bothered me working in mental health and studying it, there's a lot of mystery in mental health. And one point I often make is that mental health professionals should be much more transparent of that mystery. I'll give you an example. If you're giving someone a diagnosis, let's say of ADHD, and I'm going to use ADHD because often that's talked about in the media with a lot of certainty. Give someone a diagnosis of ADHD, that's often talked about with a lot of certainty, like ADHD is this really biological brain-based disorder. I think that's not true, actually. There's no tests that can definitively say, you have ADHD, no biological tests. It's all done by clinical interview. That doesn't mean I don't think ADHD is a useful diagnostic construct. And actually the treatments for ADHD are really good compared to, say, depression. So I think there's a lot of mystery diagnostically. There isn't a huge lot of mystery, and I think you make this point in your book a lot, about what makes a mentally healthy life or what is more likely to give someone mental being. And often it's talked about like there is a lot of mystery, but I don't think there is. So could you speak to that a bit? Like, is it that complicated for someone to have a life that's going to be maximally likely to give them some good mental well-being?
It is and it isn't, in the sense that I guess it's an age-old human question of how we live a fulfilling and meaningful and, life. And that's a process and a journey everyone goes through. But in terms of when people really reach a point where certain experiences or responses to their lives are, inhibitive and just preventing them from doing the things that make someone feel good enough. Yes, it's pretty obvious. And, it is things like I've mentioned, like just having a roof, just basic needs met, roof over your head, enough to eat, not having to worry about money too much, having people around, community, exercising, just all of the things that we all know and talk about kind of, just in our cultures in various forms, just make people feel good. And when those things are missing, or when someone has a really difficult experience, experiences violence or some kind of trauma, that makes them feel not good. And that's then something they need support with. And it's all, and it's not straightforward. It's always a process. And like we've been saying, it looks different for everyone. But when you are able to, like you said, diagnose the problem as a social one, as one that exists in the context of someone's life and in the world, then you can begin to respond in a way that will help to some extent, definitely. Whereas, a medical diagnosis may or may not.
I think I would probably diagnose the problem as this constant interface between our biology, our psychology, this is the biopsychosocial model, the constant interface and interaction between our biology, social landscape, and our psychology. But on this point, I guess one other point of tension, at least for me, is this balancing between personal responsibility and collective responsibility. They both seem to be very important. A person needs to have responsibility for their lives because only they can make the best choices, for their lives. You talked about agency earlier. I'm a huge fan of the concept of agency and inspiring agency in our patients and clients. At the same time, when we're dealing with nation states of hundreds of thousands to millions of people, at that point, you could argue even in a family of four, collective responsibility comes into play at some point. Like, an individual isn't just responsible for themselves, but an individual is to some degree also responsible for everyone else. And we have this shared collective responsibility. This is a super difficult question. I'm not expecting you to have a straightforward answer to, but how do we start to balance those? Where do we draw the line between what an individual is responsible for versus what society at large is responsible for?
Well, I guess if we're talking specifically about, mental health, I think it just depends on how we frame the task or the challenge. And when we frame it in terms of our responsibility is to cure people, that leads to a very different distribution of power to when we say our responsibility is to facilitating choice for individuals. And when you see it as that as the collective responsibility, then you can start to think about a system and how people might work in order to empower individuals rather than remove,
right,
their abnormalities or bring them in line. So I think that, to me, that's how you bring those two together. It's about thinking about what you're actually trying to do.
Yeah. So what support does someone need to be able to make choices? They'll need shelter, as you said. They'll need a certain amount of wealth. They'll need opportunities, like opportunities to work and so on, opportunities to meet people and form relationships. So you're saying what are the bedrock supports someone will need to be able to even get to the point of seeing choices?
Yeah, well, that, and also facilitating choice in terms of the care they receive. I use examples of, for example, in the Netherlands where I am right now, they're trialing a system of care where people really design their own kind of treatment based, not just, they can choose to take, drugs like antidepressants if they want to, but might also want to access meditation, yoga, and they're supported to kind of make meaning out of their experiences and then figure out how they want to respond. And the assumption is always that someone in a system like that is always that someone can choose, rather than the opposite assumption, which often starts to take over, more traditionally in mental health care systems based on the medical view, which is that people are, not capable of making decisions, that they're somehow risky to themselves or to others, that they need to kind of be led. And I just think that's a very different assumption that leads to a very different form of care, just always trying to protect as much as we can the sense of agency, the sense that someone does have a choice in how they want to be in the world and how they want to live their life. And we also know that when someone doesn't feel that they have that agency or choice, when they feel powerless, it's, one of the biggest causes of why people feel mentally, unwell in the first place. So it's just, to me, has to be so integral, has to be, a central value to delivering care.
Yeah, absolutely. And I've made the argument quite often that we lean too hard in taking on all the responsibility as mental health professionals because we are worried about risk.
Mm-hmm.
And even though risk is a real issue in some extreme situations, I think that filters down to a lot of situations with clients and patients where we feel we have to, on some unconscious level, make choices for them.
Mm-hmm. Mm-hmm.
And I think the phrase which applies in what you say when people feel like they don't have choice is learned helplessness. People feel a sense of learned helplessness. In other words, no matter what I do, I'm going to get the same result. And I can't think of a psychological factor that would lead to depression more than learned helplessness. No matter what I do, just I'm going to get the same outcome, the same bad outcome over and over again.
Completely. And it makes me think a lot. I also use some examples of care systems delivered in prisons. It makes me think a little bit about those, because there's also attempts to, there you have this real, imposed power discrepancy between, the people in charge, guards, or whoever's working there, and the inmates. And in kind of attempts to innovate and help and support prisoners in a different way, there's also this idea that as long as you treat someone as, a prisoner, as someone incapable of making decisions, that's all they will ever be. And when you start to create a supportive environment where, what they call pro-social behavior is modeled, and people are able to form relationships and try things out a little differently and grow in that way, that there's a possibility of someone making changes. So yeah, it's very much about projecting what what you're hoping to kind of cultivate.
Yeah, and along similar lines, one thing I have seen in mental health systems, not all the time, but I've seen it often enough, is there's this illusion that there's this really bright line between really good functioning mentally and having a severe mental health condition, or what you could call the boundary between sanity and insanity, say. Is that wrong? Is that wrong? Is that not a bright line? What do you think people need to know about the boundary between good and bad mental health?
Yeah. I mean, I think, again, maybe these concepts of good and bad aren't so useful. I think it makes me think of, peer support models, where I worked a lot with an organization through my work at Mind who go in and deliver training for mental health care professionals and psychiatrists as well, and really encourage them to relate to the people they're working with on a more, experiential, just human level, sharing experiences where maybe they struggled, where they had a difficult time, rather than perpetuating this idea, like you said, that one of you is well and one of you is unwell. And I think that's that's probably really healing. And I think that it gives people a lot of hope to, and makes people feel less alone, to kind of talk to someone, realize that other people go through difficulties too, and that it's not an inherent problem within you, but just something that all people go through in different ways to different degrees. And, that we're all dealing with this hardship. It's this coming together, in these, or through these experiences that we share as humans, that is just missing from this kind of system where you have an expert and a patient who needs help.
Yeah, if there's any advice I would give to anyone training in mental health, or anyone seeing someone in a healthcare context, it's like the only thing separating you from having the same kinds of problems your patients might be having is genetics and environment. And you can argue about which is more important, and that'll be different in different situations. But regardless of the proportions, you don't choose your genetics. and you definitely don't choose your early life environment. Maybe you can start to choose your environment later on. People who don't believe in free will would also debate that. But you certainly don't choose your genetics and early life environment. And that's the only thing separating you from them in some sense. If you had certain genetic predispositions or certain stresses or traumas, social deprivations, you might be in very much the same situation. Very important to appreciate. You could have a week that's so bad that you could be in crisis yourself, and it's so important to understand that. I think if you can really understand that, you then sort of bring that into the consultation with you, and it filters down to how you speak with a patient, and they understand that you're not talking them from a place of separation, but actually a place of like, let's connect, see where you're coming from, and let's kind of work together.
Yeah, no, it's really interesting you saying that, because it does make me just wonder how many of us really do see that it's, chance and circumstance that separates the people who suffer from the people who don't. And at the same time that we all suffer, of course, to some degree. And I think just a lot of the kind of discourse, the way these things are talked about nowadays, things like self-care really frame mental health as a personal responsibility. And so what follows is, if you are struggling with your mental health, you haven't done enough. And it's that really individualistic view, that again does connect with the medical view, which makes this an individual problem rather than a social problem, where we don't see the social structures connecting us that, make this a collective human experience. And you miss that, and it leads to feelings or ideas that about that of superiority, that people who are not struggling with their mental health as much are somehow better. And I think that's where the title comes in, no such thing as normal, and we started with that. And also, the spectre of kind of eugenics in mental health, and just this idea that people who suffer are somehow innately inferior. And I just think we need to do everything we can to make sure we never, go there again.
Yeah, because even if you could make the argument, like even if you could say, let's say the path to not having any kind of mental health problem is to be really hardworking and conscientious. And I don't believe that's true, but let's just say for a second it was true. That is also a personality trait that is influenced by genetics and environment, which you also did not choose, like heavily influenced by, entirely influenced by those two things. So even when people say it's about hard work and industriousness and responsibility, that is subject to the same influences. So then for me, the question becomes, because I think, these personality traits are actually really useful and important. The question becomes, how do we, again, create an environment that makes people as conscientious about their own lives as possible in a way that's helpful?
Yeah, I think make people feel safe, make sure their basic needs are met. I think it's simple. People, it's very, person-centered sort of ideas about, just like you were saying, kind of just human actualization, but just give people a relatively, safe environment. And I think those kinds of behaviors that are supportive, that are helpful, do start to flourish, but it can't happen without a supportive environment.
In a couple of chapters towards the end of your book, you start to explore a couple of newer frontiers in mental health. The first one being psychedelics. What do you see? How are you seeing the psychedelics movement? Is it? Do you think it helps to initiate the paradigm shift that you'd like within mental health? Do you worry that through the psychedelics we could fall into the same traps that we've fallen into before in mental health?
Yeah, both. I think that I see a lot of the sort of attitudes and ideas from the kind of psychedelic kind of movement, or the use of psychedelics, that I think can be really supportive of just the idea that individuals, are just vastly different, that there's a certain element of kind of exploration and risk involved in any form of transformation that, again, is just a highly individual process. There's also the kind of nod to other kinds of cultures and traditions and other ways of making sense of our mental experiences that, aren't necessarily pathological, but might actually show us something. And I think that when these substances are used, in some kind of form of support with a therapist or some other context, they can definitely show people something new, or offer a new kind of reference point or kind of experience that might weave into their process in some way. But I also see how, in a kind of hyper just commercialized context, there is this risk of psychedelics being sold as miracle substances, much in the way that antidepressants were in the 1990s, and that they will be, offered as this one-stop cookie cutter kind of cure for supposed, uniform experiences. And you can see them being discussed in that way as these kind of breakthrough, solutions that anyone can benefit from. And that loses everything that I think the origins of psychedelics, but also just the possibilities they offer would really help to facilitate. So it just depends so much on how we use them, how we frame their use, and just how they're introduced. And I'm not overly optimistic that it will be in the sort of empowering kind of paradigm that that they could be, because money usually wins.
Yeah, the cool thing about psychedelics is that they, we have an opportunity to use a biological agent that gives someone like a window of opportunity for psychological change, where they don't need to be dosed continually, like a once a day dosing. They might have, let's say 2 or 3 doses in a treatment, and maybe that's it forever. And that's an amazing opportunity. I worry, I think, largely about the same things you worry about. Like, for example, I worked in a place once which had a ketamine clinic, and ketamine has been studied and shown to be useful for depression. But I was just surprised there was no psychotherapy around the ketamine. It's almost, ketamine seems to be occupying a weird place where it's kind of seen as sort of a psychedelic, but not really a psychedelic. I don't really know why necessarily. I don't necessarily think the reasoning is super solid there. But I think then for that reason, it was given in this context. It often is given without therapy, and I think that's probably a mistake. And so I worry about the same things as you, that these medicines would be distributed sort of stripped of any sort of psychological, cultural context. And it's just like, take your psychedelic and you don't have to think about your life or anything like that, and everything will get better on its own. In terms of like capitalism as the engine for developing these medicines and therapies, I'm kind of torn. Capitalism is in some ways great for innovation and distributing things to large numbers of people. At the same time, capitalism has a history, not always, but often, of stripping things of their context, maximizing profit. You see it all the time. Just to take a really trivial example of like a really great restaurant chain, like 3 or 4 great restaurants that gets bought by a private equity company, and then they scale it and they end up like making a really terrible version of that originally great restaurant. So it's not like being in business at all is bad. Business can be useful, but is it going to go the same way where the actual product is diluted purely for profit? I suppose that would be the concern.
Yeah. And also the question of accessibility, who gets access to this in a way that, it needs to be accessed. We're talking about the importance of a supportive, some kind of supportive context, whether that's a therapist or some other kind of situation, that the substance in and of itself won't necessarily help someone if those conditions aren't there. And just the way these things tend to go is that, the more kind of careful, supportive, elaborate care won't be accessible to people who can't afford it. And, that would just be a real shame.
Mm-hmm. I'm moving on to the subject of neurodiversity. I think what's interesting about neurodiversity from my perspective as a clinician is, in the past, I think, there's a whole conversation to be had about mental health diagnosis and how to do that well or not so well, how, reliable our diagnostic constructs are. But just from my perspective, I've given a lot of people a mental health diagnosis. Often that's met with either some sadness or some difficulty, but sometimes some gratitude and thank you for explaining that this occurs in other people and what it means and what these symptoms mean. But it's a kind of sort of slightly subdued reaction that you kind of expect with any kind of medical diagnosis. If you tell someone they have diabetes or high blood pressure, a kind of subdued, sometimes gratitude, sometimes upset. When it comes to neurodiversity, the change that I've seen is that people are very, very excited and enthusiastic about their diagnosis. And that's something I'm not sure how I feel about that yet. On the one hand, there is people getting a diagnosis of, let's say, autism or ADHD after struggling for a long time, 40 years, 50 years, and never having a good explanation. And I understand the enthusiasm in that context. On the other hand, I worry about people making their whole personality about one particular diagnosis. Oh, my ADHD explains pretty much everything about me, or my autism. Often patients might arrive at an assessment already having reached the conclusion that they have a particular diagnosis, and then feeling that that's going to be helpful to explain everything about them. So I worry about these two sides. Is that something that you saw in your research for the book?
Yeah, it's a really interesting question, and it makes, me also just, and I can see why people would be excited at receiving a neurodiversity diagnosis, just because of the way it's kind of framed culturally today as a very positive kind of, sometimes almost kind of necessary aspect to your personality. Like, just the way it's discussed today it's almost more of a, what kind of neurodiversity do you have? Not do you identify, or do you have a diagnosis of some kind of neurodiversity? But I guess it just makes me wonder what people think getting that diagnosis actually means. Do they think it means, I can understand that just understanding yourself better, or having a language to explain your experience to others, can be very helpful. And I can see how it might also bring a kind of relief. But I guess I worry nowadays about neurodiversity, which, has its origins in a kind of social model of disability. So this recognition that it's not the actual impairment, say, in physical terms, maybe the lack of a limb or some kind of function or mechanism of the body, that's not the issue itself, but that the world disables people twice over by failing to support, difference. And that was really the origin, of this kind of thinking. It was actually subversive of the kind of biological view that says, this is the problem, and challenged institutions and medicine and, care providers to respond to people's needs as they saw them, and to offer reasonable adjustments. Nowadays, I feel like it's often discussed once again as an individual, diagnosis that then needs attention and treatment and care. And the focus has shifted very much away from, social provision again onto individuals and, what, drugs or other forms of treatment they might be. And with that, it's also been kind of repathologized as often a problem or something to be cured. Whereas, there's been so many activists and movements and efforts to move away from that kind of deficit thinking, in cases like autism, away from a view that autism is a disease and towards an understanding that people with autism just experience the world differently in many ways that are, enriching to them. Sometimes not, sometimes there's difficulties too, but that this is a very multifaceted experience that can't just be, erased, or that the aim should never be to get rid of it, but to support people just where they are and how they are. So yeah, I guess that's my concern around just the uptake of these labels and the way they're kind of talked about today.
Yeah, and I think we very much need to appreciate how much both of these conditions we've mentioned so far, autism and ADHD, are very much a spectrum, and things look very different at one end of the spectrum than another. Mild ADHD, and I see a lot of people in ADHD clinics, mild ADHD looks very different to severe ADHD, and in my view needs kind of a different approach. Similarly with autism, at one end of the spectrum, you have individuals who might have quite a severe learning disability, might be nonverbal in some cases, in which case it does fit that medical paradigm better. But then at the moderate or milder ends of the spectrum, then you can make arguments that these ways of thinking and processing information can be quite adaptive. And I've actually had some interesting conversations about this from an evolutionary point of view, that it might make, obviously it can make sense to have people around in your community who see things and process things in a different way. So I think it's a complicated issue that's still really, we're still kind of at the beginning of, and still very much starting to understand. Again, any clinicians listening, I think one thing I might emphasize is just be open, like do the best research you can and be open with your patients and clients that there's still a lot of mystery we're still trying to figure out. There are some things we know, there's a lot of stuff we don't know yet when it comes to neurodiversity especially.
Mm-hmm. Yeah, and I think, this mystery that you've been talking about, I think is also just so useful in kind of undercutting this power discrepancy between, someone who supposedly has all the answers and someone who doesn't. Just an openness, like you say, about what we didn't know and what we don't know, and offering people options.
Mm-hmm. We've talked a little bit about what directions a mental health system might move in, helping to support people, to address social problems, to inspire people towards agency. Are there any good examples of services within the UK who seem to be making good progress in this direction?
Yeah, I mean, I think there's so many actually. And, having worked in a kind of a smaller service within Mind in Hackney, I've seen the amazing work that specialized services and local services can really do, that have really specialist knowledge of a particular community and a particular type of experience. I also, there's other services within Mind that I think are just so, groundbreaking, although they shouldn't be, like the Hearing Voices Network, for example, that works with people who hear voices and rather than pathologizing the problem or trying to kind of eliminate the voices, works with people to form a relationship with them and sometimes even, come to like them, appreciate them. There's peer support services. There's all sorts out there. I think the problem is generally just how fragmented the kind of landscape is and how people get often bounced back between services and their GPs and kind of caught between the cracks. And there's a real need for kind of bringing them together, better resourcing them, coordinating them. But there's so many, depending on the kind of help and support you want. I would always really advise people to kind of look locally and go to, charities and just see what a range and, diversity of approaches there are out there as well beyond, going to your doctor. There's also, all types of community support. Of course, we have social prescribing now as well in the UK. So yeah, I think there's actually a lot out there. It really needs more funding.
Yeah, I think really good services, especially in mental health, often start locally. Small organizations know their community really well.
Mm-hmm.
But then there's the scaling problem as things get larger, and you see this in the NHS. As things get larger and you're dealing with larger amounts of people, there's a scaling problem where it's hard to deliver that same like high quality, very personalized service to large numbers of people. And I feel like this is maybe one of the core problems we need to grapple with as a society. How do we get a really good local service and scale it up? I saw this in the NHS all the time, where you'd have one particular team, one department that just works really well. And the thing you had to do was leave them alone as much as possible. And their job, the leaders of those departments, their job was to try and hide from managerial oversight as much as possible, to just like keep doing what they were doing because they had a good team and a good culture. So this is one of the biggest problems I see in the NHS, is how do you scale a service that's already demonstrated to work really well. I've talked about Chester in Italy quite a lot. They've done a really good job, and they've done a really good job in Chester. But then how do you scale it across Italy, for example? It seems to be a very complicated issue.
Yeah, I mean, it is. And, it would be, huge reforms. But like I said, I was looking into the Dutch kind of example and how they're trialing currently, in specific areas, but working towards a national coordinated system where they're really, based on kind of a modular approach where there's lots of different local services, but there's one kind of coordinator helping someone through and coordinating the care they receive through different local services. And yeah, so I think just with the right investment and thinking it can really, it's possible.
Yeah, no, definitely. Even though a problem is complicated, we shouldn't pretend like it's not possible, because that's obviously simply not true.
Yeah, agreed.
We're out of time, but Marieke, thank you so much for spending some time with me today. Your book, No Such Thing as Normal, Disorders, Diagnoses, and the Limits of Psychiatry. I'll put a link in the description so our listeners can check it out if they're interested in learning more about these topics. Thank you very much for joining me.
Yeah, no worries. Thanks for having me once again.